As all of you probably know, we have two types of weekly webinar meetings. One type is the subject matter experts like Geeta, who's on here, who talked about genomic expression. And we then query them, and people get an opportunity to find out what the services are, and often they then can get access. The other type of meeting we have is the type we're having today, which is where a patient reviews their case. I'm looking at Mike Yancey, who did that. Brian's done that. Rick has done that. And so that gives us an opportunity to get feedback from the community. And often what we find is the patients have explored some of the same sorts of issues and can share their experience, what they learned, what worked, what didn't work with each other. So that's the kind of session we're going to be having today. So Amit will be presenting his case and the questions that he has, and then opening it up for comments and shared experiences. Thanks, Amit.
Thanks, Brad. I assume you guys can see my screen.
Yes, the redwoods.
The redwoods. It's a picture I took about a year back in California redwoods. I just thought it's appropriate for the title, what I'm dealing with. So I'm a visual person. I take a lot of pictures. I think you guys know me, but just wanted to introduce, who we are, right? My wife, as you might have seen in the description, this picture was taken late last year, family picture. My wife is a physician herself. She's a hospitalist at Kaiser here in the Sacramento area. We live in Granite Bay, Sacramento area. My daughter is 21. She's about to graduate in a month from NYU Tisch in theater and film. So one of my goals and current goal is just to be actually able to get there and travel to her graduation, which, as you'll see, is not a very trivial thing right now for me as we go through my journey. But it's one of my immediate goals that, yes, I want to be able to, in a month or at least 3 weeks from now, I want to be there in New York to see her graduate. And my son is freshman at UCSC. He just started this year. So both kids are out of the house. And this is a lovely dog, Biscotti. He's 11 Labradoodle, Australian Labradoodle. This picture was taken a couple of years back where there was a massive bloom of lupins here in Folsom Lake. And when the water levels are very low, then we get this kind of bloom here in the Folsom Lake. This year, the water levels are high, so we don't have a bloom like that. But he hangs out with me all the time. Yeah. This is the medical panel. I've been working with Dr. Ashna at Kaiser. She's the kind of my primary oncologist. Dr. Jonathan Chow at UCSF is my other primary oncologist. Both were fellows of Dr. Eric Small. She came and worked at Kaiser. He's at UCSF today. They coordinate my care really, really well because they have known each other for a while. They worked with Dr. Eric Small, kind of trained together, and they really are the kind of the primary caretakers of my kind of the decision makers. Dr. Manish Kohli, he's a very well-known academician, and Geo Ong, he's currently at Huntsman Cancer Institute, holds a bunch of these academic chairs and stuff like that. He's always a kind of go-to consult on the side. We know him personally very, very well. I can call him on a Sunday morning and he'll spend an hour with me on the phone and will just walk us through things. He's very well connected in the industry, so he connects us to many other people as needed. He's the one who made the connection to Dr. Antonacoris also. So he's always on consult. Also been working with the integrative oncologists for a couple of years at UCSF. They kind of try to help with all the kind of the non-traditional methods and manners. It's been a good kind of interesting journey to work with them. I won't say anything, fundamentally different has come out of it, but it's always good to have an integrative oncologist. So that's kind of my primary team. As I said, we have talked to many other experts in the past. I haven't listed them here, but I did do recent extensions, had a consult with Dr. McKay that many of you know.
You got it? Okay.
Dr. Rana McKay. especially this was related to the BAT discussion that has been kind of hot and going on here, right? So I did have a consult with her last week, a full extensive consult. Dr. Emmanuel, we've reached out to him. I haven't talked to him. He said he will talk directly to Joe, and he did, to discuss my case and then decide whether there's something worth pursuing or not. And I'll kind of get to that in a bit. So this has been my kind of journey to date. Most of you guys have probably seen this thing, as data oriented we are, we kind of try to track everything, oops. At one point I needed log scale because the PSA was kind of gonna go low, right? From 200 to 2.2 and stuff like that. But I'm kind of way past that. I'm running into the 400s and 500s now for past 18 months, right? So kind of the scale of a lot of this stuff is kind of gone away. It started late 2018. I won't go through everything in detail, but you can see the treatments have gone through chemo, Extendi, Zytiga, all the ADT stuff over here, various radiation here, radiation, then went through the immunotherapy trial along with the lutetium as a kind of primer. Really didn't work. You can see what happened in the immunotherapy trial over here during that phase. Then it started chemotherapy again. It helped bring some control back there, the challenge with the Taxotere stuff. And then I was really, really keen on Pluvicto. I mean, for 18 months, I was tracking, I was willing to travel the world to get Pluvicto treatment. If it didn't become available, fortunately, it did become available over here. And when it did become available, we did switch to Pluvicto over here after the chemo. Had 3 doses of that, really kind of didn't, it's unclear what it did or didn't do over there. And then things have just been kind of, moving along over there. And I'm kind of back on this 8th line right now of chemo, and I'll talk about why and where we are. But I want to kind of point out radiation stuff. Around this time, I have had focal radiation to take care of certain focal things over here. Last July is when I started to have massive spinal issues in my lower in my lower back, and that's when high dose kind of radiation stuff has started. And we'll talk about what how that whole journey has kind of gone in a little bit. So the big stuff and findings in past 3 months, beginning of the year, things were starting to look okay. I'm done with Pluvicto. We don't know what's next. Things, at least I was symptom free and everything else, but it didn't last long. In Feb, I started to have very serious pains in my, In Feb, I started to have very serious pain in my thoracic spine. July was lumbar spine. This time it was thoracic spine. Massive nerve compression from being on vacation in India. In a week or 10 days, I couldn't even walk. So it was pretty bad, and had to get radiation treatment to take care of that. Which helped over a period of time, but it left some nerve compression issues that have persisted. After that, my walking has been unstable because I lost some nerve senses that haven't fully recovered yet. Same time, the PSMA scan indicated that now the disease has infiltrated the bone marrow quite extensively. So the disease that was in the bone, and we knew it was in the vertebrae, it started to go on both sides. On one side, it started to kind of get into the spinal channels. On the other side, it started to get in the bone marrow. So it didn't stay in the bone itself at this stage, right? So on both sides of the bone, it started to infiltrate bone marrow as well as the spinal channels. So that reduced significant bone marrow capacity for me, and other treatments didn't contribute, obviously, because everything suppresses bone marrow. Other finding that happened simultaneously was that my biopsy showed that I'm not pure adenocarcinoma anymore. There's a 20% neuroendocrine component involvement in cancer. So now we're not just dealing with a prostate cancer, we are dealing with an endocrine component. And my medical panel is most worried about that part also at this point. They believe that all the stuff that we've done with prostate and everything has also tried to manage and contain some of that, but it has given the chance for something else to grow, and controlling that is the hardest part at this point. I was recovering from all of this stuff from Feb and March, trying to kind of rationalize my new normality. And in April, about 2.5 weeks back, I started to get numbness on face. So actually, left side of my face is very numb, and it has been progressing. Probably you can't tell by my expression, but I'm actually pretty frozen on the left side of my face. And that was an annoyance. At least it wasn't pain and annoyance. But what happened last weekend was that my vision is messed up. So I'm actually at my computer screen level, I can see okay. But at a distance, I'm seeing a double vision. So each eye is okay if I kind of just have each eye is okay. But the nerve pressure or what the stuff that has built up in there has changed the ophthalmic stuff that I cannot actually see properly now. So now I cannot drive. My walking, which was already impaired, now is further impaired because of, taking steps and visual stuff is kind of messed up. So anything 4 or 5 feet distance and beyond, I'm having difficulty seeing clearly. So, I put an eye patch as needed and try to look like a pilot whenever I feel like, but that's all how I'm managing, right? So the MRI shows compression of various cranial nerves in a skull base. And then besides the cranial, and I'll share the MRI, the disease, what they're calling is become meningeal carcinomatosis, or it is very ready to go in the brain at this point is kind of the concern, right? So the quality of life, as you can see, has suddenly drastically shifted and changed in what I'm able to do or not do. And that's obviously kind of where things are and the big concern is, right? So the medical panel's concern is that mutation and spread disease is out of control with no prophylactic pathways at this point, right? And a spread to brain and other organs is actually very hard to predict. So far, okay, it's bony disease, it'll cause pain, we'll know how to manage pain, radiate, this and that. I think this is kind of, my sense from the medical panel is this is out of the box now and we just don't know. So count every day as a good day and you just don't know what tomorrow might or might not be, right? So here's kind of what's happening, sharing some of the MRIs also. So I had an MRI beginning of March, same MRI, and that was okay. That was non-actionable. Within 4 weeks, and this MRI is from April 14th. Within 4 weeks, you can see the growth of the disease. This is the skull base and the kind of Meckel's cave area that's called. On my right side, there is kind of the compression, but it's still okay. On the left side, which is where my face is frozen, you can see the difference between the right and left side in measurements, if you can tell, right? So there's a pretty big compression over here that is causing my facial stuff to kind of get all these nerves pressed. There's a growth in temporal lobe area also. It's not marked. Supposedly, it's not causing any symptom. But it may be hard to tell that there's the skull and brain lining, right? So between the brain and the skull, the dura that is there has white caking at this point, and that is the meningeal stuff that has everybody most worried about right now. So the plan is I'm starting radiation today. Actually, my appointment for radiation is at 11 o'clock today. I'm starting radiation to address this area. This area is not going to be addressed right now, and this area is not going to be addressed right now because it's unclear if addressing this area will cause benefit or cause more cognitive damage and bone marrow reduction also. So it's just wait and watch and see where things go and try to kind of deal with that. But what has my medical panel most worried about is more of this kind of stuff where things are getting in the dura, and what will they do when they press against the brain and loss of cognitive function. These are some of the older, since we're talking about kind of how the spinal stuff has happened. This was July 2022. This is my lumbar spine. You can see my L1, L2 area was completely compressed. So it disabled me. radiation helped me get out of that mess and really kind of made me functional again. This is February of 2023. This time it was thoracic spine. This area is completely blocked off. So moved from lumbar, thoracic to now kind of the head and the base of skull stuff. So that has been kind of how the cancer has moved from bone to my spinal cords and stuff. And part of that, this is that the adult bone marrow factory or the large capacity areas of pelvic bones, which were radiated heavily along with the lumbar spine. My pelvic bones were radiated in July. Spine is the big area where bone marrow production happens. Radiation happened 20, again, July in February, and I'm starting now. Breast bones is another area where good reserves of bone marrow factory is. And the skull, which is possible future radiation, which again, the concern is that it'll reduce more myelosuppression. So while I'm dealing with all of these and all the radiation fixes have been good to get me functional, the effect of radiation on bone marrow suppression has been actually meaningful. And now bone marrow, so to say, is my limiting factor for treatments because my cell counts are very, very low and everything else suppresses cell counts further. So that has become a limiter to what my kind of the treatment look like. I've included this for data because we all love data, but I won't go through in detail. But I was, for almost 3.5, 4 years, I was kind of keeping well with the treatments. I was tolerating them well. I was dealing with them. They weren't working, but I didn't have a tolerance issue with treatments and stuff like that. You can see hemoglobin kind of was, not great, but at least hovered around in a respectable stage. July, when I said the big radiation treatment happened, and then quasi, Pluvicto, all of that stuff happened between July and September. That's when my, hemoglobin started to tank. And, since then it has been kind of, okay, let's do something to prop up. These are my blood transfusions that I have gotten over past months to try and kind of prop up. As you can see, just about the beginning of April, I was at 6.4. 2 blood transfusions later, it has kind of propped up, and you can see all the WBC and RBC counts also, right? So yeah, I can get blood transfusion, packed RBCs, and all that stuff. Platelets really are the chemo limiter, right? My platelets dropped beginning of April, so I started this chemo. So the regimen left for me at this point was just to try and do chemo, and I'll kind of get into the details of why that is specific chemo. But the consensus was carboplatin plus cabazitaxel is the chemo that we need to give it a try. It's not targeted therapy. We need nuclear option and try and see if that can help contain. Carboplatin is very toxic, but we had to take a chance with that. And we started with that on March 1st with a smaller dose. So generally they are 3-week cycle dosage. I was only given a small dose on a weekly cycle just to see what happens. After 3 dosage, 2 of carbo and 1 of cabazi, you can see how my platelets dropped to almost kind of 60 level. Safe level is about 100 before people try to treat you, and platelets are not something you can prop up very easily or in a sustained manner, right? So this is really, platelets are the chemo limiter. So then I was on a 5 weeks break to get chemo. It started to did recover. Of course, I got blood transfused, 2 transfusions, but platelets did recover by themselves, which is actually good news. And then I did get another cycle of chemo last week, and I don't have data after that. But this panel is kind of my life limiter right now in terms of, I don't qualify for any trials for the reasons that my, hemoglobin CBC panel is very, very low. The fact that I have a neuroendocrine differentiation, I'm rejected from all the trials at this point. So experimental stuff is out of the woods. Of course, we can talk about off-road therapies and things like that, but no systemic trial. I was kind of on the books for various trials we keep discussing with UCSF, but right now, none of that is a roadmap option. So kind of where am I treatment option-wise? As I said, chemo, carboplatin, and cabazitaxel are kind of the go-to options from the medical panel. Carbo, because it actually targets neuroendocrine. Also, it targets CDK12 mutation, which has been one of my primary drivers. It has some PARP inhibitor benefits, which is a secondary to all of that. And then Cabazi is the remaining Taxol to try and address the prostate cancer part of it, right? They've been trying to get to a doublet therapy to combine both of those things, but it is too toxic, and we have not been able to combine. I'm actively on this treatment, I would say, limited to small dosage delivered in last 2 months, balancing, so we look at things where things are, dose decision, when to give, all that is made on a weekly basis, just based on where things are, right? So that is kind of the primary path. Effect of that on PSA, so to say, really, it hasn't been measurable. PSA came down from 490 to 476 after the 3 doses. So, okay, 15 points drop on a 500, really kind of, we don't know. And at this point, team is less focused on PSA because it's not the neuroendocrine indicator, right? So yeah, PSA is interesting and we'll keep tracking, but that's not the only indicator for me at this point. It's about everything else, right? So the primary path is really kind of, okay, what mileage can we get out of this, and how much can I actually tolerate this? As I said, radiation, obviously, if I can unfreeze my face and fix my vision issue, those are huge quality of life issues for me right now. Starting today, it'll be a 10-dose setting to try and address that. So we'll see how that goes. Radiation full brain, again, address compression on meningeal lining. It's a possible roadmap item. I have very debatable data from various panel members about whether to do it or not do it. So it's not a decision that needs to be made right now, but it'll be, if and when it comes, we'll have to figure out if that will make sense. If I am not able to tolerate these, or become refractory, or they cannot be given, there are possible couple of chemo options. There's a topotecan, which has nothing to do with prostate. It's all post-platinum neuroendocrine kind of thing. Data comes from small cell lung cancer, may not be very relevant. It's a roadmap possible item. Again, I'm at a stage where there's not too much we can worry about, because things change so fast and quickly that, okay, yeah, it's there. When we have to make a decision, then we will figure out whether that choice is still the relevant choice or not. And then another chemo, which is a kind of a Hail Mary effort for preventing organ metastasis. Again, very speculative, possibly a roadmap item at some point, kind of thing. So none of these actually are prostate cancer related drugs. They are all kind of trying to now prevent neuroendocrine growth in other parts of the body, so to say. So it's pretty limited and short kind of list over here. I have some reject options over here. I'm sure there'll be more that is of interest to this panel, and I'm sure Olaparib has always been on my roadmap because it targets CDK12. It's on hold at this point because it's even more toxic than carboplatin. So carboplatin is kind of supposedly a poor man's Olaparib, and if I cannot tolerate carboplatin, then Olaparib is a dead thing for me. And carbo has a little bit more benefit at this point with neuroendocrine than Olaparib, doing the CDK12 mutation. So it was always a roadmap item. We never got to it, but at this point, it's like, oh, this is going to be way too toxic for me to even consider it. I know back has been a big kind of discussion, and as I said, because it's non-bone marrow suppressive and obviously it'll target, right? It has been rejected universally by my panel, including Dr. Rana Meke, who I consulted. very recently, specifically for this. The reason is that at this point the concern is the cancer is way too aggressive, and flare-ups, while for most people can be transitionary, it may be too hard to control, and the permanent damage that it may create, paralytic damage, could be very, very unpleasant. So they just don't think I'm in the zone where this is even worth the ROI or the risk. So as I said, all three of my oncologists rejected it. Dr. Reina was not supportive right from the very first time I asked her about that. Dr. Antonakoris, he's willing to say, hey, come up to my clinic in Minnesota and we'll review the case and then see where to go. I have to decide whether, when and whether that will make sense or not, but the offer is open for him to meet with me in person in Minnesota and try to let him judge that. But I've kind of put that on back burner for now. I know Thus has a hand up. Thus, do you want to say something now, or you want me to get me through this?
Yes, olaparib. Who told you it's toxic? Curious where that came from. My MO says it's not toxic at all. And the trials I've seen, it seems like there's a little toxicity, a few side effects, but I'm wondering where that came from. It's more toxic than chemo?
More toxic than carboplatin. Multiple oncologists have told me that.
Huh,
okay. my medical panel oncologist.
Interesting.
Jonathan Chow, Manish Kohli, all of them believe, and even Dr. Rana McKay,
I'm not okay. So they all say the same thing. Is it more toxic in your case, or because of white blood cells, or some parameter maybe?
It's for the bone marrow toxicity, for my hemoglobin and cell count, for cell count stuff, right? So okay. So thanks. Various trials, again, based on genomics and everything else. We had, ARV targets, bispecific antibody, CAR-T. I'm kind of, as I mentioned, all of them are off the table. Other drugs, these are some of the other drugs that have come up. Not enough evidence data, ROI to focus on that. There's few open items, again, from Cure Match, again, based on some of the esoteric data of few genes here and there, but and I'll get into genomics in the next page a little bit. Is that stuff is very low priority for my onco team. We can find like, oh yeah, there's a small gene here that this has this stuff, but they're focused on the bigger picture of what's happening rather than, okay, what if I address that specific gene, which is a very small expression at this point, and we don't know whether that is a driver or not a driver, right? So I had a very good conversation with the Ali also last week on Cure Match. I'm keeping them on the list, but as I work with my medical panel, there's like interesting, but that's not actionable, or where we can put focus, because doing something has always a opportunity cost of not doing something else, and they have to make that call bedside on where's the right, what is it that they can deliver, rather than go chase a small nuts here and there, right? So that's pretty short list of things. As you can see, my real path right now is this, and this is for symptom relief, and this is kind of the systemic therapy at this point. Beyond that, everything is just like, we don't even know what can or may happen or not happen. I'll cover a few pages on genomics and then pretty much open to discussion here. I've been using Guarded as kind of the reference point almost periodically. So it's kind of a good reference point over here. All these reports are on Google Drive if anybody wants to take a look at that. As I said, CDK12 has been a driver mutation, and we've been tracking it. It's been there. That's why olaparib was there. on the list always because it targets that. Besides, and olaparib also has very weak data, by the way, on CDK12. So it's the only, so to say, FDA-approved drug that has some data, but that evidence was actually very, very weak. It seems like they snug it under at the last moment of, oh yeah, this can help. So it has been okay, interesting, we'll look at it, but it was not like a massive belief and evidence on data. AR amplification, as I said, has been high, so that's why the BAT was also always interesting. Other stuff has been kind of pretty relatively low and kind of gone from being there to ND level, so you can see kind of how things have tracked, right? BRCA2 was never there first time. In the last report, something kind of showed up, and that's where the carboplatin helps with BRCA2 also. So carboplatin is now a little bit of a more multifaceted approach for me. So that has been my kind of the Guardant history. Well, I did, just for reference point, I did Tempus XF plus panel because we are talking about all of this. And really kind of the surprising thing is that there's very low set of consistencies between Guardant and Tempus. And that makes this decision-making really, really challenging, right? CDK12, yes, both of them have it. It's there, it's relevant. We can debate what the reference allele frequency is, but we have known CDK12 as the driver, right? Everything else, there was like, is almost mutually exclusive between Tempus and Guardant, right? So if there is some DNMT3 here, which wasn't in Guardant. There's mTOL, which again, they list that as variants of unknown significance. So they say it's not actionable, but mTOL is very high in case of Tempus. You look at mTOL in case of Guardant, it's non-detected, ND level. It was there a little bit and now ND level. So my kind of key thing is that there are very low set of consistent data points with which my medical team is like, okay, let's go make a decision to target this. I mean, CDK12 we have known forever, AR we have known forever. Everything else is like, okay, interesting, but without consistent and validated data, it's like, what are we trying to chase here? Yeah, we can include some mTOL stuff or ERCC6 stuff, but you're also calling it variants of unknown significance. Other reports don't show it. So it all goes back to how good is this data? And I think the industry, at least it feels like the alignment between industry and the medical practitioners on how good the data is and how to actually effectively use when things don't match up across genomics is not there. And people don't have time to actually keep chasing small stuff right now. Here's the proteomics analysis. It was done on tissue. It didn't really produce, again, anything meaningfully actionable out of it. I mean, again, won't go through the detail. AR amplification, AR proteins are high. We've known that, right? There's a TUB3 protein. They say maybe there's some likely benefit, but it's non-detectable. So it's there, non-detectable level, but maybe something can be done about it. And they put carboplatins for the ERCC1 protein in a unlikely benefit because of some resistance marker. So I've shown this report to all my oncologists. It's like, don't know what to do with that. I think carboplatin has a good benefit for you, and we're going to stay with carboplatin. That's kind of their experience with that stuff right now, right? So what it comes down to is that it's interesting data, but it hasn't become meaningfully actionable for me or my panel to say, okay, really, this is cool. It gives me an action plan, and I'm going to go act on this stuff. So that's the unfortunate reality of all the kind of the genomic stuff that I'm dealing with, right? So as I said, carboplatin becomes kind of its neuroendocrine CDK has some PARP inhibitor benefit, and that has become kind of hey, if I can tolerate and take carboplatin, that is likely the a good option for me along with cabazitaxel. And if I can get to this doublet, which so far hasn't happened, that's kind of my primary path. So that's all the data. Here's kind of, I'll just now open it for all the feedback and stuff, right? Physical health and symptoms, it's just, I'm getting regular setbacks, as you can see, right? In March, as I was recovering, I was thinking of EWOT and, how can I strengthen my physical body, do this, doing physio, everything else. It's just like now I have a setback that, significant setback in my body's weakness, as well as ability to see, ability to, walk, all that stuff. So I'm still trying to figure out, how to keep recovering from that while going through the treatment, right? Roadmap has limited me. Frankly, the conversations are palliative at this point is, hey, we can keep throwing toxicity at you at this point, but at some point, there isn't much left here to throw at you, and we just have to make a decision where that line is. Genomics I've already talked about. Managing quality of life and what's my best quality of life path is obviously a priority for me, because without quality of life is kind of what is life, right? So that's kind of where I am physically, medically, and mentally on. Yes, we are starting radiation. Hopefully that will help unfreeze my left part of the face and give me my vision back, because without vision, what do all the joy of travel and all the joy of meeting people gets significantly impacted. I'm very focused now internally to try and do what are the most important things in my life at this point, because I really don't know what tomorrow is or isn't. And the meningeal stuff, stuff coming to the brain and paralysis, nothing I can do about those concerns. At least, again, we can try and radiate the skull, but it's not a simple slam dunk thing that what it might or might not do. So that's pretty much it.
Okay, we have about 15 minutes left in our time. So that was a lot of content. There's been a furious conversation in the chat. I don't know if you've been able to see it, Amit, but let's start with
No, I have not.
Yeah, Rick had about 8 or 10 comments in your questions. So Rick, why don't you take it away? And then Russ has got questions, and Jeff and Brian, I think. So let's start with Rick, because he had a lot of questions.
Rick, you're muted.
You're muted. You're muted, Rick.
Sorry. Some of these questions were more pertinent as we were going, but I'll just run them down. Pluvicto, any biomarker to believe it would work? Did you have any PSMA quantitation done?
I had PSMA scan before and after. The focal areas of my disease seem to have distributed a little bit. So things that were as dark were not as dark. So I think it probably helped in some areas, right? But it didn't contain the PSA. It didn't contain a spread of the disease to other disease and stuff like that. It didn't give me extension of life, so to say, or time. And it probably caused more bone marrow suppression also in the process.
Okay. So you've had a fair bit of SBRT, right?
Mm-hmm.
Would proton have been less harmful or less side effects?
So I've had SBRT and VMAT, which is a volumetric modulated arc therapy also. VMAT was needed because of how bulky my spinal areas were, and how they needed to be treated. So far, touchwood radiation has always been very effective for me. So I can't say whether proton would have been even better. I will think about it or ask, but so far, radiation has really helped me get out of the pickle. In those things, both SBRT and VMAT.
Yeah. Okay. And then I think getting into the mTOR, there is I'm looking for a way to help because I believe there's mTOR inhibitors, and at 53%, well, going to the CDK12, I just don't even know. This would be, something Richard might hop in on, but it looks like, you have one allele that's mutated of the CDK12, and that's a loss of function. But at 53%, I didn't see another one. So you have a single hit. I don't know. I'll ask Richard, anything you would interpret from 53% or 55%, or, basically you have one hit that's for both the CDK12 and the mTOR. So going to the CDK12, I have a double hit, so you have a single hit. Is there any comments there? I think I'll ask Richard to shed light, or maybe get
Richard, do you mean this Richard?
Yes, the Richard Anders who always knows so much and always corrects me and from embarrassing
Oh no, I only correct you on the small number of things I know something about. But I mean, I think that, and I don't honestly know anything here, but I think it's the problem that there are two conflicting liquid biopsies. I mean, you don't really even have a clear signal.
Okay, then let me finish up and then anyone so with the it's a missense on mTOR, but there are a variety of scores that you can predict the deleteriousness of a missense. So back in, I can't think of the name, but we would run various scoring techniques or algorithms to determine the deleterious nature of a missense that wasn't one of the classics. So has anyone done that? Because these two SETBP1, these two look like something could be done here, because these are strong signals. So I guess no one's done anything like that to try and say, hey, this is no big deal. It's just a missense on this part of the protein, and we know how it's folded, and it's off here and not a binding site. Or, hey, this is right. This is not a good missense. Has anyone done anything?
So when they report this as unknown significance, what does that? What is it saying by itself? Okay, they measured it, but they're saying it's of unknown significance.
Yeah, the doctors will give you a different answer than a bioinformatics guy.
Yeah.
So it's in the unknown significance part because there's no direct linkage to our knowledge. But just being a curious guy, and I'm looking for ways to help. From a bioinformatics standpoint, we would rate every variant. Got the scoring, but it's really a sophisticated scoring algorithm that goes across species. It goes, inheritance, or how old is this particular section of the genome, and it predicts a deleterious score. And maybe because right now it's in this, we don't know what to do with it. A doctor will tell you we don't know what to do with it, so we're not going to act on it. But maybe since you need some options, maybe maybe you would look at that.
Sure.
Maybe
so I would love to.
Maybe one thing you could do, it would take time. It'd probably be expensive. I don't know if it'd be worth it, but some of these variants of unknown significance, you just don't know if they affect the folding or the action. I mean, that they're a mutation, that they're not like wild type, but you don't know if it'll do anything. Sometimes variants of unknown significance are totally benign. They don't do anything and they're just a variant. Possibly what you could do is, make a PDX model with some cells if you could get it, and then test it on an mTOR inhibitor.
And that was
would only
Brian's questions too about getting an organoid or doing some functional testing.
with that as I'm thinking about it is that would tell you if the mTOR inhibitor knocked down the mTOR mutant, but it wouldn't tell you if the mTOR mutant was actually driving anything.
Yeah. Okay. I hear you. So getting an organoid test, which I kind of saw somebody had recently, right, requires live tissue taken live right now, and I don't have an opportunity at this moment to get another live tissue that can be sent to lab within 48 hours of being taken out. I'm going to get a solid biopsy done from Tempus on the tissue that's already there. It's work in progress, and then kind of see what comes back from the solid biopsy from Tempus on that particular thing, and then kind of go. The question is the question I get from my panel is interesting, but is that the biggest area that we need to focus on right now? And the answer always comes back from everybody no. So I'm just being honest.
Who's you're talking about your panel of doctors?
Yes.
Yeah. I mean, it doesn't have to be a monolithic effort. I mean, we can deploy other resources to support what they're doing, and so I wasn't, using an organoid or building an organoid, I knew it was going to be difficult, right? Just because of the tissue challenge that you have. So I wasn't putting all my eggs in that basket. But I'm wondering if there's some computational models just based upon, the sequencing that you've done that could help us understand the menu of treatment options. What do we think is going to work and which ones don't we think are going to work? And Brad, I don't know if, we've got, was it Magnus Felke at Clemson? I don't know if Pete Kane could potentially help in this effort. But it seems to me like you've got data. You've got some treatment options on the map. Can we at least be smarter about which ones we think are going to work and aren't going to work?
Yeah, so I'm open to what we can do with this data, right, in parallel. So adding multiple therapies right now is just very difficult because I'm not tolerating a single therapy right now, right? So adding even more multiple therapies is like, okay, yeah, we can, but if I first have to show that I'm able to tolerate or deal with the primary therapies. So that's kind of where the real time things is, but putting it on analysis and roadmap, absolutely. So maybe Brian, you and I can chat offline and see what kind of.
Yeah. So if we were to pursue computational models, I'm sure we would need raw data. Do you know if you have any raw data?
Well, we did XF Plus panel just so that we can get raw data. I haven't asked for it, but I mean, that was the whole thing. We worked with Tempus too, so that we can get the raw data. And then I'll have the solid biopsy stuff kind of going on and then get the raw data from that as well.
And the solid biopsy you're going to do with Foundation or?
No, with Tempus, just
with
so
Tempus.
that I have.
Okay.
Yeah.
Yeah, I know XF Plus is I think like 500 genes, so the raw data maybe a little bit limited on that front, but the tissue hopefully could potentially open up more doors.
Yeah.
Shino has his hand raised.
Hey, Amit. A quick question with regards to your AR levels, right? And I probably missed this, but what about your androgen deprivation therapies? I mean, have you had any of those things?
Yeah, I became refractory to those pretty early on. I mean, I went through, wrong direction. Extendees Zytiga stuff way back in the early days. over there and became refractory. I mean, you can see that I got a little bit of control, but it really never kind of held things back, right? Maybe slowed things down.
Because what we observed was your AR levels is actually the second or third highest in our database. So like for comparison, Brian's level was 911 or something like that, and yours is 3,200 and change. So you actually have an extremely high AR levels. That's borne out by proteomics. That's also borne out by Garden Health genomics testing as well.
Yeah.
So I feel like that's a point of attack. So and that's something not experimental. That's something that you could go with the conventional therapies.
Cabazitaxel is the conventional therapy that will address the AR, right? I mean, the taxanes.
No, taxanes address tubulins.
Okay, that's true. Yeah.
So for
AR,
what
conventional
you're looking at, you're looking at apalutamide, enzalutamide, all those.
Zytiga, darolutamide.
Yeah.
So again, we
or a degrader.
Yeah, like Arvinus, ARV 110 or 766. I forget which one.
The Vita. I mean, we talked about doing a V trial with Extendeo Zytiga at some point, or doing a kind of a. It didn't. The data from my kind of panel was that it's very, very low probability that retargeting will help. But I'll bring that up again.
Yeah, because your February biopsy had one of the highest levels of AR receptors that we have seen. And that's definitely something that should be important on the table.
And Sheena, I think he's going to have a conversation with Emmanuel Antonarakis. I mean, what about bipolar androgen therapy? I know it's sometimes can be risky, but with his high AR expression, he doesn't have TP53, but it would seem that would be a pretty good match for BAT.
I'm not that conversant with it, but enzalutamide is one of the pieces in the BAT therapy, right? But you're actually turning off signals, so you actually need to turn off the androgen receptor signaling, and with the high levels of AR, so conventional androgen deprivation therapies might be useful here. And this was from I know you stopped Zytiga way back, I guess, but it probably need to get reintroduced, these androgen deprivation therapies, because that's a path.
So I'm on Lupron, by the way. Lupron is a consistently. I'm on Eligard Lupron, by the way. That hasn't gone away.
Yeah, so that was what one really that stood out for me. Your androgen receptor levels is high when both us and now Garden Out has shown that.
No, that's known. So Lupron has been a consistent parallel. I'm every 3 months on Lupron, basically. So I should have been more clear about that. Yeah.
Sheena, do you have any targets for neuroendocrine disease?
Yes, we do.
Yeah, I wanted to kind of
Amit does have in his report. I was looking through it. Does have some markers for neuroendocrine markers, like chromoganin A, CHGA. I think he does have it. I was looking at his report. Yeah, he has an extremely chromoganin A is definitely there. I mean, chromoganin A, synaptophysin, and CD56. These are 3 markers classically used for diagnosing neuroendocrine tumors. So his levels of chromoganin A is very high, like 7,000 plus something.
And so are there treatments that target those expressions?
There are typically nothing to target those 3 biomarkers. They are more to say you have neuroendocrine tumors, and when you do have neuroendocrine tumor, you switch to etoposide platinum, which is, I guess, part of etoposide platinum therapy is part of that cocktail, right? So I believe you are on platinum and
So etoposide is kind of part of the same platinum thing, right? So I'm on platinum, carboplatin stuff.
Well, you're on carboplatin, which is different from etoposide. So etoposide is targeting topo2A. So I think Mike Yancey had switched to that regimen, etoposide platinum. So you might have more insight on that.
So my understanding is that etoposide is given as a doublet therapy, not as a single therapy, and it is given with carbo, right?
That's right.
So they're working with carbo. If I can tolerate carbo, and then Kabasi, then etoposide is an option on the table. But again, etoposide by itself is not a single therapy, is my understanding.
No, they usually think, physicians usually think in terms of cocktails when it comes to chemo cocktails. So so you're on carboplatin and cabazitaxel, right? That's a cocktail together.
Right.
There's also cabazitaxel carboplatin cocktail, and you have etoposide and carboplatin cocktail.
Cocktail, right. So right now the priority is carbo plus cabasi, so that you target both neuroendocrine and prostate. Going to carbo plus etoposide would be neuro only targeting.
And it makes sense from our report. The cabazitaxel is basically an anti-tubulin inhibitor. So you don't have the resistance marker for an anti-tubulin, which is what the TUB3 non-detected meant. You don't have resistance marker for anti-tubulin, so you should respond to cabazitaxel. That's
right.
But for me, the thing that really stood out was your AR was like number 2 or number 3 in our database.
Okay. Let me just do a quick process check. We're over the hour. Amit, do you have some more time?
I do till about 10:20 or 10:30. So then I have to go.
I will let Russ ask his questions. I might stop the recording and let us keep going, but Russ, you had your hand raised.
Yeah, thanks. I have a cold, that's why I'm mostly muted and my video stopped. Anyway, I don't want to have you guys have to listen to my hacking or see it. Anyway, if you did entertain BAT or you did it, I strongly advise using an oral testosterone undecanoate for 1 day, or androgel even, because they or even a propionate possibly, but I wouldn't even get. They have very short half-lives, and the oral testosterone undecanoate has a half-life like 2 hours. So whatever you would see with it would be really quick and it would wash out fast. So if you ever did entertain that, I would definitely advise that, going a really short half-life to see how you're reacting. If somebody agreed with that, or if your MO would let you do that.
I agree with it.
Then the other things about the PARP inhibitors, there are other PARP inhibitors. They're not all approved. There's talazoparib. I don't know if I'm butchering the name. Probably am. It might have worse toxicity for you, a hematological parameter or toxicity. But then there's, and I think it showed, I read a trial yesterday or the other day, it had better benefits better benefits than olaparib. Then there's rucaparib, which I don't know if you've talked to them about that. I don't know what its side effect profile is.
Getting the side effect profile is a very, very difficult challenge that I've been kind of struggling with, right? You have to kind of rely on the oncologist to say that, because I had this long discussion with Ali on that topic also. If there's a way to really quantify the side effects in various ways of something. So again, it's not that thus if you can send me in the chat the names that you said, I'll kind of keep adding them to the list. I've gone through many of those things in the past, and they kind of get in the reject. Like we were just talking about the etoposide that brought up, right? Again, it's there, possibly at some point again consider looking at, but for the reasons that I explained, it's not on the table right now. And then I think I have to get through.
The top side is very different as the top two. Yeah. Okay.
So PARP inhibitors have not been a big driver for me, right? PARP inhibitor again.
These are not PARP inhibitors. The two I mentioned are not PARP inhibitors. They're PARP. Did I say PARP inhibitor? They're PARP inhibitors. Like
that's what I meant.
Similar to olaparib.
Yeah. So PARP inhibitors, other than CDK12 targeting, have not been a big target area for me so far. So my panel, if I look at all of the doctors, everybody is, I'm worried about the neuroendocrine right now. What do I do with that? All this stuff is very interesting, but I'm worried about where your neuroendocrine is going. Right? That's kind of where the head is for everybody individually, for all the 4 doctors that I'm working with. Right? So yeah, all the PARP inhibitors and everything else, we can keep having long roadmaps of things, which again is always a good thing to have. But I'm just saying practicality is, if there is something related to neuroendocrine control, that is what is.
I don't know. I don't know much about neuroendocrine and prostate cancer.
That is what is of most kind of interest.
So Sheena mentioned etoposide for neuroendocrine. Did the doctors mention that?
Yeah. This is the same etoposide that.
Oh, I see it. Okay.
Yeah. We have discussed etoposide. Etoposide is part of has been part of the conversation.
Okay.
Yeah.
Just to underline, Jeff Krolik had a couple of ideas just for quality of life. I don't know if you saw those, but they were things to deal with your pain. They're not the same kind of medical neuroendocrine kind of treatments, but just for quality of life. A couple of ideas there.
I haven't had a chance to look at the chat, but
Jeff, are you still on? Maybe you could just give voice.
Yes, I am still here. So yeah, I went with more of a complementary approach in quality of life, looking at increased comfort, reduced pain. All acupuncturists are not equally skillful or are as knowledgeable with maybe some Chinese herbs. I mean, both of those have some research track record for improving quality of life in TENS machines, which are often used to relieve chronic pain. Related to that is a very similar system called frequency-specific microcurrent. Physical therapists can do that, and it's quite effective in relieving many different types of pain, and even generates a cell fuel, ADP, in a certain way that can actually benefit some cancers in terms of reducing the load a little bit, but I wouldn't go there for treatment. These are really all quality of life, palliative care kinds of things.
Okay. I do go to acupuncturist twice a week. I've been kind of, based on my integrative oncologist, I've been doing that. I think it keeps me calm, probably helps me. It's hard to kind of isolate the effect of that, but I am actively in acupuncture as well. I will look into your suggestion of the frequency specific microcurrent stuff and we'll see whether that is appreciated. Yeah.